Good evening. Welcome to today's Café. I'm Dick Jayas, Vice President of Research and International at the University of Manitoba. These cafes are an initiative of my office, and the purpose of these cafes is to bring our esteemed researchers together close to the public in a more very friendly and comfortable environment. We have a topic that is important to all people, preventing a fall, which can happen at any age or any stage in our life, and I particularly today was very careful walking coming forward on this session. Our research group at the Center on Aging focus on this topic will share what they have learned and no doubt assist us all with some tips for staying safe and active through the winter this year and beyond. I would now like to introduce your moderator for this evening, who will tell you more about the panelists and some of the ground rules that will guide the discussion this evening. Dr. Michelle Porter, on my immediate right, is the director, or immediate left, is the director of the Center on Aging at the University of Manitoba. In addition to her duties as director, she is a professor in the faculty of Kinesiology and Recreation Management, also at the University of Manitoba. She received her PhD in Kinesiology from University of Western Ontario, her Master of Science degree in Community Health from the University of Toronto, and her Bachelor's degree in Physical and Health Education from Laurentian University. She spent her postdoctoral fellowship in Boston and Sweden. Michelle's work with older adults extend back to her undergraduate studies, where she volunteered and worked with older adults at residences and hospitals, and at academic research centers, including the Dr. Paul Swan Center at University of Regina and the Center for Activity and Aging at University of Western Ontario. Please welcome me in joining Dr. Michelle Porter.
Thank you very much, Dr. Jayas, particularly since you just flew back from Dubai this morning. So thanks for being here. Now it's time to get some sleep. Okay. So I just wanted to tell you a little bit about the center before I get us underway this evening. At the Center on Aging, we have about 80 research affiliates who come from almost every faculty at the University of Manitoba, and also Brandon University and the University of Winnipeg. And they study a diverse array of aging issues from a variety of disciplinary perspectives using many different methods. The center has existed since 1982, so this year we're actually celebrating our 35th anniversary. So one function of the center is to bring together researchers who study similar topics related to aging. And one of these research groups is a newly formed fall prevention research team. And tonight we have a few members of the team here to discuss fall prevention. The fact that we're holding this in November, you might ask, why would we be holding it just after we have our first snowfall and the roads are slippery and the sidewalks are slippery? But this is because it's Fall Prevention Month across Canada. And if you'd like more information regarding fall prevention after this meeting, I'd really encourage you to take a look at the web page that's associated with Fall Prevention Month. And its address is fallpreventionmonth.ca. So all one word, fallpreventionmonth.ca. And on their website, they have activity ideas, information, lots of information, and a lot more. But I did want to also tell you a little bit about fall prevention in Manitoba. So according to the Manitoba Fall Prevention Plan document, falls remain the leading cause for injury, hospitalization, and deaths in Manitoba. Falls and associated outcomes not only harm the injured individuals, but also their family, friends, care providers, and the healthcare system. These are quotes from this document. Each year, over 5,000 individuals in Manitoba are admitted to hospital due to a fall. Rates are highest both for children and older adults, with the highest rates being for those 85 and older. Although, as Dr. Jayas said, falls can clearly happen to anyone at any age. Fall prevention is complicated because there are many factors that can increase risk for falling. Tonight we're going to specifically focus on balance and mobility, how these factors are related to falling, and how they can be improved to reduce the risk of falling. In just a few moments, I'll introduce our speakers and I'll stop talking. But first, I do have some housekeeping items in order to orient you to what's going to be happening tonight. So each of our panelists will speak for about 5 minutes, and they're going to give their perspective on the topic for tonight. After all the panelists have spoken, I will open up the floor for discussion or questions. And then I'll be bringing this microphone around so that we can make sure that everyone hears the questions and the comments. You might notice that there's a camera at the back of the room, and we are video recording this session, and it will be on the University of Manitoba's Café Scientifique website. And there will be a link to the video posted on the umanitoba.ca Café Scientifique website next week. But because of this, I would like you to try and keep your comments free from very much personal information, particularly information that could identify other people. Once we get to about 8:25, we'll finish up with the questions and wrap things up for the evening. Some of you have already partaken of the refreshments up here, but feel free to help yourself throughout the evening. And you will have noticed that there was an evaluation form on your chair, so we'd appreciate you filling those out before you leave. So that's it for the housekeeping items. And so that brings me to introducing the panel. And I'm going to introduce each person just before they speak. So our first speaker is Dr. Jonathan Singer. John received his PhD in biomechanics from the University of Waterloo in 2012, followed by postdoctoral training in neuromotor control at Sunnybrook Research Institute in Toronto. He joined the Faculty of Kinesiology and Recreation Management in January 2015. John's research aims to advance knowledge of the specific neuromechanical mechanisms, I'm sure I'll explain more about what that means, by which humans maintain stability and apply this information to understand why clinical populations such as older adults and stroke survivors experience challenges with stability control. The long-term goal of his research is to enable the development of targeted interventions and technologies to help individuals maintain or regain independent mobility and reduce the risks of falls. Welcome, John, and take it away.
Okay. Good evening, everybody. Thank you all again for coming. So I just wanted to pick up on a comment that Dr. Porter made right at the get-go, talking about fall-related deaths in Manitoba, and it's certainly true for fall-related deaths in Canada as well. And when I'm in my professor mode, and I have my nice PowerPoint slides behind me, and I have my computer in front of me, and I'm able to show very nice graphs. One of the graphs that I like to show is this over time change in the number of fall-related deaths and deaths due to fall specifically. And so if you looked at this graph, what you would see is sort of this upward trend of fall-related deaths among older adults in Canada, and certainly true for around the world as well. And I like to compare that to the trend of deaths due to motor vehicle accidents. And if you looked at that graph, you'd actually see sort of a downward trend in the number of deaths due to motor vehicle accidents. There's a number of factors that relate to this, but essentially when we look at a population standardized rate of fall-related deaths and motor vehicle-related deaths, it sort of takes out the fact that there are more older adults today in society than there were in the past, so they're due to sort of intrinsic factors that are specific to the population today, not just to the fact that we have more older adults in our society. And so what this means, essentially, to me anyways, is we're generating these really nice, safe vehicles for people to drive around in, but we're not doing a very good job of making people safe when they try to ambulate or move around in their environment. And so I think the reason for this, or one of the reasons for this, is that humans are complicated. I mean, to put it very simply, humans are a very complicated system of interconnected systems. Researchers often talk about this issue of the balance control system, and we often relate falls to this balance control system. It's sort of this black box where there are a number of individual inputs to this black box, and there are a number of outputs from this black box. So I usually talk about this from the perspective of like a computer. So you have a CPU that sits on your desk, That's really like the brains of the computer. It's like your central nervous system, your brain, your spinal cord. And then you have these peripheral things, these printers or speakers or mice or computer mice or keyboards that are the inputs into this. And so in your computer, your CPU, you have all these outputs, printer, monitor, speakers, and you have these inputs that are like your keyboard or like your mouse. And the balance control system is very much like this. We have a number of inputs, the sensory inputs that go into our brain and tell us where we are in space and what are the forces that we're kind of creating at any one particular point in time. And then you have these motor outputs as well that are essentially muscle forces that you generate. The difference between a computer system and a human system is that the computer system, the individual components aren't really interrelated. So this would be like if I told you that when you look at something on your monitor and then you go to print it, what you see when you print the piece of paper would be different depending on what kind of music you're listening to at the time, which doesn't make any sense. If you're listening to Bob Dylan or listening to Mozart, it shouldn't have any influence on what you get printed out from your computer. This isn't the case for the balance control system, where all of these individual sensory systems, your visual system, your vestibular system, your somatosensory system, which tells you where your body is in space, and the motor system, the muscle forces that you generate, they're all very much interrelated. So it gets challenging to try to tease apart how all these individual systems relate to one another and then relate to balance control. So it's a really, really complicated system. We do know that older adults tend to be a little bit more visually dominant. We know that deficits in any one of the systems can lead to poor balance control. So older adults tend to be a little bit more visually dominant, meaning that if you have a cataract or loss of visual acuity, you tend to be a little bit more at risk of falls than would a younger person who had the exact same visual challenge. We also know, we know some biomechanical things as well about how we regulate balance. So when there are sort of two modes of balance control we tend to think about. One is a standing balance mode, a static balance mode, although the term static is really a misnomer because we're never truly still, perfectly still. And then you have a dynamic balance mode where you're moving through space. So when we are standing up and just trying to maintain your stability, looking at the books on the shelf and just pulling books off and taking a look at those, you tend to try to keep your, what's called the center of mass, which is a point in space sort of right above your belly button. You try to keep that over top of your base of support. And your base of support is really an area that's bound by your feet. So if you took a piece of chalk and you sort of traced around the outline of your feet, that would be sort of the area of your base of support. You're trying to keep your center of mass over top of that area. We tend to try to do this by executing forces in our lower leg muscles, really your calf muscle and the muscles on the front surface of your shin, to move something called your center of pressure. And your center of pressure, you can actually feel where your center of pressure is. For those of you who want to put both feet flat on the floor, and you can execute sort of a toes down rotation, push your toes into the floor, and you can feel more pressure underneath your toes. And you can also pull your toes up, and you'll feel more pressure underneath your heels. So we use the muscles in our lower legs to regulate the position of this center of pressure, the center of force underneath your feet. And by doing this, we're able to generate forces that push our center of mass forward and backwards. So there's nobody standing right now, but if anybody wants to stand and try this, you can stand up and let yourself fall forward just a little bit. And what you'll do to try to restabilize is move this variable called the center of pressure forward by standing up on your toes. You're trying to move that as far forward as you can. According to our friend Mr. Newton, he had a third law that says for every action there's an equal and opposite reaction. So by moving your center of pressure, this variable forwards, it's actually pushing your center of mass backwards. And if you're falling in a backwards direction, you'll move your center of pressure as backwards, as far backwards as you can, and that pushes your center of mass forwards. So you're constantly doing these regulations of the position of the center of pressure by generating forces in your lower limbs to try to keep your center of mass over top of your base of support. In a dynamic sense, when you're walking, it's essentially the same kind of scenario, except instead of just regulating the position of the center of mass variable, you're trying to regulate the velocity of it as well. So every time you walk, your center of mass exits this base of support. It's no longer underneath your feet for a period of time. So you're generating these forces that always are trying to push your center of mass back underneath your base of support during every subsequent step that you make. So that's the biomechanics of essentially how we regulate our stability, how we regulate our balance. But sort of superimposed on all of this are a bunch of control modes, or two control modes specifically. And so one is an anticipatory control mode, and that's when we try to sort of preempt or pre-stabilize ourselves before we disturb our own balance. So an example is standing at the kitchen sink doing some dishes. You dry your coffee mug and then you go to put it up on the top shelf on your, in your cupboard. And in order to do this, you need to pre-stabilize before moving your arm. By moving your arm, you're changing the position of your center of mass, you're destabilizing yourself, and so you're generating these forces in your legs to try to pre-stabilize yourself before you disturb your own balance. So that's an anticipatory control mode in the quiet standing or in the static stability sense. We also have a reactive balance control mode as well. So if you're standing at the bookshelves and somebody walks by you and bumps you, then you need to generate these movements of the center of pressure very, very quickly in order to keep your center of mass within your base of support. And again, the same holds true in a dynamic sense, except the dynamic sense is a little bit more complicated. So you can think of, I have a 2-year-old at home, and I know that in my playroom, the floor in my playroom is just strewn with toys. So I have anticipatory mechanisms when I walk into that room to try to figure out where I can place my feet that I will be stable as I walk through this room. So I'm trying to create a plan of where I'm going to place my feet and what are the forces I'm going to create when I step so that I maintain my stability. I'm trying to generate this movement plan to pre-stabilize myself. Similarly, on the reactive control side, if I'm walking and I slip on ice, or if I'm bumped by somebody, I can generate these movements of my limbs. Sometimes it involves grabbing onto something. You'll see oftentimes somebody quickly grabs onto somebody's hand beside them if they slip, grab onto a railing, or generate a step. And so all these things are reactive things that we can do, reactive control mechanisms that we can execute in order to maintain our stability. I'm sort of the mindset that the reactive control element or the reactive control equation is a lot more important than the anticipatory control element. So all of you today probably walked through your environment and had a lot of balanced destabilizations, a lot of perturbations. Many, many times you probably didn't even realize they were happening, and you didn't fall. And the reason is because your reactive control system is very good, and so you're able to reactively restabilize in the face of any of these balance perturbations that you would have come across on any particular day. And so this is why you don't fall. And so I think again that the reactive control element probably a little bit more important than the anticipatory control element. You can disturb your own balance and still recover from that. You can undergo a slip, trip, and still restabilize after that, as long as you have good reactive control. So what I'm trying to do in my lab now is try to understand the relationship between some of these sensory systems that subserve this balance control system, this quote-unquote black box, and try to understand how the reactive control mechanisms are related to all the sensory systems that subserve our balance control system. And if we can find out the mapping of this, potentially we could use this to determine what an individual's control challenges are. You could come into the lab, we could put you through a number of individual tests, and we could hopefully determine what your deficits were in balance control. And then maybe we'd be able to assign you a particular intervention, whatever that might be. It might be correcting your vision, it might be trying to use some balance-enhancing shoes potentially, it could be assigning you to an exercise intervention that would be specific to your balance control challenge, not just sort of the blanket approaches that we use now where it's one size fits all. So I'm hoping that at some point in the future we'll get to this point where we can have an individualized balance assessment and then potentially prescribe treatments that are specific to the challenges that individuals are having.
Thank you very much, John. Okay, our next speaker is Dr. Kathryn Sibley. She's an assistant professor at the University of Manitoba. Kate was recruited to Winnipeg in 2014 after completing her graduate training in rehabilitation and medical sciences at the University of Toronto. In 2016, Dr. Sibley was awarded a Canada Research Chair focused on integrating knowledge translation and rehabilitation sciences. This is a prestigious award that acknowledges her as an exceptional emerging researcher with the potential to lead her field. Dr. Sibley's research has closed major gaps in the use of evidence on fall prevention for older adults, and her innovative approach that involves health professionals, people living with a health condition, and health decision makers as research partners is stimulating a paradigm shift in health research. Kate.
Thanks, Michelle. Thank you, John. I always like presenting with John, and I like when he goes first because he gets to talk about the hard stuff. And then I get to follow up with that. So I'm going to spend my comments talking a little bit about how we can build on all of the great knowledge and evidence that John and our colleagues have built up from the laboratory environment to what you can do to prevent a fall, because there are things that we can all do to help avoid falls. But the important thing is that there are different things that are going to work to prevent falls for different people. So it's this sort of funny issue, right? Because the end product, the fall, is sort of the same for many of us, but what causes that fall can be very different from person to person. And so that's why we talked several times already about how fall prevention can be quite challenging and complicated, because for it to be most effective, we have to figure out what exactly is the problem in each individual. And so we're only going to be able to give sort of general comments and general advice tonight. So, as John said, I often like to think that the common denominator when it comes to falls is a loss of balance. At the end of the day, you fall because you had some sort of loss of stability and you weren't able to recover, and that is what led to that is what caused you to fall. But you may have all of these other issues that contributed to your loss of balance. So maybe you couldn't see that there was a rug or a cord in front of you that you tripped on. Maybe you're starting to lose some sensation in your feet and you weren't able to account for that as you were walking along. So all of these sort of other factors. Maybe you have low blood pressure, and maybe as you sat up too quickly, that contributed. So there's all these sort of other reasons behind it that right now, looking at and talking to all of you, we're not going to be able to decipher. So first of all, I guess the first thing I want to say, sort of with that in mind, is that if you have a history of falls, if you have had several of them, and or you're really particularly concerned about how steady you are on your feet and your balance, the first and best thing to do would be to go to your healthcare provider, because they're going to be able to help you tease out what is the specific issue that you may or may not have, and then they'll be able to help refer you to the right people who can help you address your specific issue. So if you have a family physician, that would be a great place to start with. They're able to access other resources within the Winnipeg Health Region, provide you with specific referrals. We might get referred to a physiotherapist, and Dr. Weber is going to talk about what will happen if you see a physiotherapist later. So those are all, that would always sort of be my first starting point, if you have a history of that. Now, if you're here tonight because you're sort of generally interested in what can I do to prevent falls, if you sort of see the snow and the ice coming over the winter, I know I am starting to think about these things, what can you do sort of preemptively? And I'm glad to see so many great healthy people here in the audience tonight, because I think you're exactly the right people who need to be thinking about preventing and avoiding falls right now. This is when we can have the most impact. This is when what the choices that you make now are going to have an impact 10 or 15 years down the line, when we're really going to have to worry about your stability. So for those of us who are sort of generally thinking about what we can do to prevent falls, one of the biggest things that I can suggest and sort of recommend is balance exercise. So we heard so much from John about, we have this complicated balance system, and I like to think of it as a balance system. And so just like other aspects of health and exercise, you have to use it or lose it. So if we want to get stronger, we need to lift weights. If we want to make our heart healthier, we need to go out and do a brisk walk and get our heart rate up. If we want to improve our balance, we need to challenge that balance system. And so that's, if there's sort of nothing else you take away tonight, I would say think about what are some of the options that you can do for challenging your balance. And unfortunately, in a way, you know, it's a specific thing. Your balance system is different than your muscular system. It's different than your cardiovascular system. So while I would love to say that going out and lifting weights and doing biceps curls is going to help you avoid a fall, that's a different thing. We've got to do that too. Going out for your brisk walk is going to help your heart. That's not necessarily the type of exercise that we need to help improve your balance to avoid a fall. It really does need to be that sort of little bit of challenge. So just like you start to get your heart rate up if you're walking briskly, you're feeling a challenge there, right? We need to have those same types of balance challenges in a safe way in order to challenge our balance system. And so when people ask me, well, how do I know if it's challenging or not? One thing I'll often say is, if you have to think about your balance, then it's challenging. If walking down the street for you is not challenging, it's not going to be improving your balance. So that's always sort of a good barometer that I like to use. So what does challenging your balance mean? Well, just like cardio exercise, just like strength training exercise, that's going to mean different things for different people. What's challenging for one person is not necessarily going to be challenging for another person. And so that's why working with a trained healthcare provider like a physiotherapist or an exercise professional in a safe environment is going to be really important for you to help you figure out what is the right challenge for you. So we just are sort of nudging, right? We always want to be safe, but it's how can we just get a little bit better? So I'll give you some examples, and I'm going to stand up, I'm sorry. So one of the things that can everyone hear me if I step away? Right. Thanks. So one of the big sort of things that we know about how to challenge your balance is the idea of changing your base of support. And so that was what John was talking about. If we think about just your stance and how you are supported in life. So right now, most of you, your base of support is actually the area under the chairs beneath you as well as your feet. That is that sort of footprint that's providing you with stability right now. Right now, but my base of support is the area underneath my feet. If I'm holding onto the chair for support, my base of support is also now including this chair. So I can make my balance system more challenged by reducing my base of support, making that base of support smaller. So when I take my hand away, that's becoming more challenging. Is that challenging for me to stand without my hands? Not particularly. So if I need to make it more challenging, I can do many things. I can start to bring my feet closer together. The closer my feet are together, the more challenged my balance system is. I can make it even harder. I can stand on one leg, make that base of support even smaller. I'm going to put it down now. So for everyone, what is the right amount of challenge is going to be different. So I don't necessarily want to tell everyone to stand up, take their hands off, stand with one leg, close your eyes, do all these sort of crazy things. This is what we need to sort of figure out. But once you have figured out for yourself, or with your healthcare provider, you can start to incorporate these things into, if you're already going to the gym, you could do your bicep curls standing one leg. Now we're adding a balance challenge to that. There's also lots of ways that you can incorporate these things into your daily life. So I tell my mom all the time, brushing your teeth, stand on one leg, Mom, give it a shot, right? So there are ways that we can build in these activities throughout our daily life. And your physio and many of the exercise classes can help you with that around town. What else do we need to do? How much do you need to do, right? So I'm giving you more stuff to do. Well, the good news is, just like all things, we have to use it or lose it. So when we're talking about training our balance, we're talking about, building up to about 30 minutes a day, several times a week, and you have to keep it up. So it's not like a short-term thing that's going to fix you forever. You got to keep your muscles strong, you got to keep your heart strong, you got to keep your balance system strong. So it'll take about 3 months of really dedicated training before you start to see a noticeable difference in your balance and a noticeable difference in your fall risk, but you have to keep going. So it's just one of those things that we have to sort of build into our daily life over, consistently. It's a habit, it really is. So what else do I want to say? So if you like group exercise, there are lots of resources to help you find classes that can help you do these. There are several fall prevention exercise classes within Winnipeg. The Refit has a good example of one of those. My colleagues from the WRHA, the Winnipeg Regional Health Authority, are here tonight, and they've brought some great resources, and they have a lot of really helpful stuff on preventing falls. And they have another good website with a very simple thing you can remember. Preventfalls.ca is made right here in Winnipeg. And they have a great little class finder that you can type in your address and find out where there are classes near you. And so just some other things, last sort of comments. So in addition to preventing your things you can do to challenge your balance, there are also other general preventative type of things that are good for all of us. And those are really sort of focused on those external risk factors. So what are the things that we can do to make it so that when your balance is challenged, you're less likely to fall? So that would be things like looking at the hazards around your home, in your environment. So do you have, you know, computer cables laying around that that are a trip hazard? Are you, you know, appropriately putting salt out front of your house these days so we have less likely chances of slipping? There's all these kinds of things to do that certainly can't hurt, and what they're going to do is reduce the chances of you having a situation where you're thrown off of balance, and that's why those types of activities can help prevent falls too. Some people may need to get their eyes checked again. Again, that's the kind of thing, if you're going to your healthcare provider, they can help you with that. So I think those are most of my comments for now. So with that, I'm going to pass it on. Thank you.
Thank you very much, Kate. So our has been speaking is Dr. Sandra Weber. She's a physiotherapist and an associate professor in the Department of Physical Therapy in the College of Rehabilitation Sciences at the University of Manitoba. She completed her PhD at the University of Manitoba and was funded by an Institute of Aging Fellowship from the Canadian Institutes of Health Research. Her research generally focuses on mobility in older adults. She's been involved in a number of studies examining things like outdoor walking in older adults, ambulation and geriatric rehabilitation patients in hospital and on discharge, and physical activity in people after total knee replacement. Thank you, Sandra. Take it away.
All right, thanks, Michelle. So what I'm going to talk to you today about is not so much about my research, but more about some of the teaching that I do and more from my background as being a physiotherapist. So like Dr. Sibley said, there's lots of benefit to doing exercise to try to prevent falls and try to improve your balance. It's not necessarily going to guarantee anything if you exercise, but it's generally a good idea. And there's lots of options for exercise. Options through the community, options through senior centers, community centers, places like the Refit Center or the Wellness Institute. Another option is for you to go and visit a physiotherapist and have an individualized assessment and treatment plan figured out for yourself. Now, as Dr. Sibley said, it's not guaranteed that exercise is going to be the right thing for everybody. There are lots of reasons why people may have trouble with their balance, and that's why it's a good idea for you to see a healthcare professional and make sure that other things are evaluated as well. So some of the things that the healthcare professional should go over with you are looking at your other medical conditions. For example, if someone has low blood pressure and they feel dizzy or lightheaded when they get up, that might be the thing that's making them prone to falls. You should have your vision checked regularly. The healthcare provider should ask about any falls that you've had and get some information about the circumstances around those falls. Did they occur indoors or outdoors? What time of day? That sort of thing. So once you've seen your healthcare provider, you may decide that you're going to see a physiotherapist, that you want to get a little bit of individualized input. So if you do go to see a physiotherapist, they'll start out with a lot of those same questions that I just went through, learning about your past medical history, learning about your physical activity that you normally do, how well you're generally getting around, and then they'll go into their physical assessment. The types of people that physiotherapists typically see for balance issues often are people who've had some sort of orthopedic or neurological condition. So in terms of orthopedics, it could be something like people who have osteoarthritis, people who've had joint replacements, either their knee or their hip. Neurological patients might be people who've had a stroke or have Parkinson's disease or multiple sclerosis. We also see people who don't have any specific condition, but people who are just feeling like they're not getting around or not quite as steady as they used to be on their feet. So once we've gone through that history taking and gathered some information from you, then we're ready to go on to our physical assessment. So in terms of a physical assessment, the things that we would look at is first looking at the range of motion of the main joints around your in your upper limbs and your lower limbs. So see how well you can move your shoulders and your hips and your knees, and if you've got any stiff joints that aren't working the way that they should be. We would check the strength of the major muscle groups in your body and get a feel for whether there's any deficits there that might make it more difficult, for example, for you to get out of a chair or to go up and down stairs, that sort of thing. And then we would actually check your function with some of those sort of everyday activities. Can you get up and down off a step? Can you get up and down from the chair without using your hands? Can you go up and down on your toes? That sort of thing. Once we've done that, then we'd be ready to go on to our more specific balance assessment. And there are lots of different ways that a therapist might go through a balance assessment. There are standardized assessments, like the Berg Balance Test or the Mini Best Test. And these assessments all include a number of different tasks. Some of them, like Dr. Sibley suggested, so standing on one foot, walking with one foot in front of the other, heel to toe. As I said, going up and down on a step, reaching down, bending forward, a number of different sort of progressively more difficult tasks. Regardless of the specific assessment that the therapist chooses to use for you, it will proceed in some sort of logical fashion. So we're interested in first seeing what your balance is like in sitting. So we would get you sitting on a wooden bench or stool with no back and no armrests, and have you plant your feet on the floor, and then just see how well you can manage with, shifting your weight forwards and backwards and side to side, and how far you can reach with those kind of movements, and how well you do. If we give you a little nudge in different directions, can you do that with your eyes closed? Does that change anything? Then we could do the same sort of thing with you in standing and see how you manage with swaying back and forth or standing on one foot, and then we get you up and walking and assess how you manage with different types of stepping patterns. And with all of those different postures, we can do things to make it more challenging. So we can change the surface. So for example, instead of just sitting on that nice solid wooden stool, we might have you sit on sort of a rubbery, squishy disc. Or we might have you sit on an exercise ball. That could change things a lot for how stable you are when you're sitting. For standing, as I said, we might have you just stand on one foot. Or we could have you stand on an exercise mat. Or on a more unstable foam type of surface. Same thing for walking. We can use those different surfaces, and we can use different types of stepping patterns, getting you to step over top of things, get side to side over some lines or a ladder drawn on the floor, that sort of thing. So once we've gone through that assessment and basically determined the level of what is challenging for you, then we're ready to come up with some sort of a program for you. And as Dr. Sibley said, it's really important for balance that the exercises are specific to the challenges at the right level that you need them. You also need to have a fair volume of exercise every week, so they recommend up to 2 to 3 hours of balance types of exercises, or just challenging balance activities over the course of a week. So the therapist will want to give you a number of different exercises that are both interesting and hopefully challenging for you, so that you will be motivated to do them. Usually the therapist would give you exercises that they feel that you're safe to do at home. And when you're doing them at home, they'll make suggestions like you should do them beside your kitchen counter, or beside a wall, or with your bed behind you, just in case you need something to help you catch your balance. They also might suggest that you come into the clinic and that there may be some exercises that you need to do there and that you shouldn't do at home because you may not be safe in doing them at home. Besides just having the therapist beside you in the clinic, they can also use things like a transfer belt. So it's just a belt around the waist that's got some handles on there just to make it a little bit easier to pull you back if you start to tip a little bit too far one way or the other. Some clinics would have access to an overhead harness as well. So for example, sometimes we have patients practicing their balance walking on a treadmill, and we can have a harness so that we know for sure that if they do trip that they're not going to actually go down and have a fall. So those are some of the reasons why you might want to actually do some exercises in the clinic with the therapist that are supervising you. But as I said, that wouldn't be the extent of your exercises, and the therapist would also be able to give you an idea of what is the appropriate challenge if you go to a community exercise program, and you could see whether that community exercise program is offering up the types of exercises that are going to be appropriate for you and for the level that you're at. If anybody is interested in knowing how to access a physiotherapist in Manitoba, you can access one without a referral from a physician. So basically anyone can call a clinic and make an appointment. The Manitoba Physiotherapy Association website has a service called Find a Physiotherapist, where you can look up for different areas in the province and even just specific areas within the city of Winnipeg and see where the physiotherapy clinics are, what their phone numbers and websites are, and you're welcome to look at the websites or give the clinic a call and ask them if it would be appropriate for you to make an appointment to see one of their therapists. That's basically all I wanted to say.
Great, thank you, Sandra. Okay, so now we're going to open up the floor for comments and questions. If you do want to come up here and get some refreshments, you're welcome to do that. And I'm going to be coming around with the microphone, so just make sure you wait for me to get to you before you start speaking. Okay, anyone have any questions or comments?
Thank you. I have spent about 5 years in nursing homes just visiting people that I care for or visiting friends that are there. One thing I did notice is that glasses seem to wander off and they get lost, they get moved, they get misplaced. And I'm just wondering, as a suggestion, if you're going to have somebody in a personal care home, I would take a picture of their glasses and post it on their wall so that you can identify who's wearing whose glasses. I remember going in to see my mom one day thinking, oh my God, I've never seen those magenta glasses on her ever. And here she was, merrily going along with somebody else's glasses. But it is a perfect opportunity for a fall.
Absolutely.
My second
prescription.
One question is there a genetic predisposition to falling?
Thank you.
Looking at the basic science guy. It's a good question. I don't think, to the best of my knowledge, we have an answer to that. I don't think that there's any, I mean, even if there were, I don't know how we would go about detecting that, at least at this point. So no, I don't think that there is, although potentially there is a genetic component to the way in which you age, so deficits in some of those subsystems that subserve this balance control system. So you might have a predisposition to losing muscle mass or losing strength as you age, which would then influence your ability to restabilize if you did experience a balance perturbation. There might be a genetic component to vision as well. And so all these individual systems might have a genetic component to them in the way in which they change over time as you age, and then that might influence this balance control system. But I'm not sure there's a genetic component to the system in and of itself. It's a system of other systems, so whether or not that's genetically predetermined, we don't have an answer for that this time.
Which I think could actually be a good thing in terms of what we can do for prevention, because then it's potentially more modifiable if we know that there isn't this sort of hard link to some genetic predisposition to your balance ability and your fall risk. So we could see that as a good thing in a way.
You pointed out the oodles of signals that go in and out to the complete system. Dr. Sibley pointed out that every case is unique. But in spite of all of this, are there any aspects that deteriorate with aging faster than others, or is everything going parallelly parallel down there.
I think certainly there's a use it or lose it. I mean, I think Dr. Sibley mentioned this, a use it or lose it sort of way in which we can approach this. And so, again, probably things do change differently for different individuals, but they also change differently depending on how you use them. So each individual has this maybe genetic component of the way in which they age, but then superimposed on top of that, I guess you're getting into the nature-nurture debate here. The way in which you use those systems will influence the way in which they change over time as well. So it's sort of this two-part problem where you have the genetic component, but then superimposed on that is how you use it. So I'm not exactly sure if that gets at the heart of your question.
Well, I was in principle asking, does any component of these that you mentioned, I'm sure you could mention 100 others, do any of them uniquely stand out that these go downhill faster with aging and are more predominantly a cause for instability or falling?
I don't think there's a universal, and I think it just again points to the fact that we're all so different, and depending what your life history and what your activity history could contribute to that as well. So, you know, we know that, for example, that dancers, people who have grown up dancing their entire lives, they have physiological changes in how they maintain their balance, right? So how they are going to age and how that's going to affect them as they get older, it's going to be different. And you know, these are the things I think are super interesting. I don't know how we'd ever study them, but like, believe it or not, I never learned to skate until I moved to Manitoba, and I took my first skating lesson once I got here, and I never thought about the balance challenge required for ice skating. And I went, holy cow, is everyone who has skated since they were kids, like, how is that going to influence their ability over time? Maybe people who are strong skaters, maybe we should study hockey players, like maybe they have a propensity to fall less. You know, well, no, I take that back. But you see where I'm going, right? How these things, what you do early in life may or may not sort of impact, and everyone's life is so different that that's why it's really hard to have this sort of universal answer.
Yeah, maybe I'll step in a bit too here. I mean, there are definitely some differences in some of the systems. So reaction time starts to decline at a much earlier age than, say, muscle mass declines. And so there are some difference in those physiological systems. Whether they reach a threshold that has an impact on your fall risk, that might not be quite the same thing.
I have sort of two comments. One is a myth that is sort of a conversation among my baby boomer friends that talk about our elderly parents, or we're soon to be there, and that is the fall in the sense of a broken hip, that the elderly fell and then broke their hip, but what is said amongst coffee breaks is that that's not the case, that it's the hip that gave and then they fell. I'm not sure if there's any truth to that or not, but I've heard that often. And the other is, after an elderly person does fall, and in my personal experience, it's with the hip, and any bone or whatever. So the recovery with physio is really a complicated piece of work, in the sense because you've got the elderly that may have dementia, and then you're trying to communicate with them, and the fall has had them in bedridden, not eating as well because, you know, they're on heavy painkillers for the surgery. And so where does the physiotherapy, you have to deal with the strength first and then the ability to help with the healing hip?
Okay, so I'll address the first question about whether the fracture occurs before the fall or when they hit the ground. And most of the time it is happening when you hit the ground. It is possible that some people do if they have very osteoporotic bones, or if they maybe have cancer metastases in the bones, then it is possible just with some regular types of movements to fracture, and then that pain might cause you to fall or lose your balance. But most of the time when people break their hip, it's because they've fallen and they impact with the ground. So your second question was about an older person who has potentially lots of health problems, and if they do fracture their hip, then they're in hospital and they're maybe waiting a day or two before they have surgery to get that hip fixated, and then sort of what are the priorities for rehab after that. And you're right that it is a complicated and difficult situation, especially if the person doesn't really understand what's going on or what's being asked of them. We do try to get the person up and mobile in some fashion really early, and part of the reason for that is because we want to avoid other complications. So we want to avoid them developing pneumonia or developing blood clots or things like that. So it is important that we try to get the person into different body postures, so they're sitting up and they're standing up and they're taking some big breaths and taking a few steps to the chair. That starts right away after surgery. And then we're kind of working on the mobility, so walking at the same time that we're working on some strength. But honestly, usually the surgeons they have better fixation techniques now than they did 15 or 20 years ago. So people are usually allowed to weight bear right after surgery, and not necessarily full weight bearing, but sort of at least half weight bearing, partial weight bearing. So it is very possible for them to walk, and so they don't need to stay in bed for a long time. We can try to avoid some of those complications. So it is a matter of trying to make sure that their pain is under control. We try to get going on the walking, and usually that does come along, at least for short distances, faster than a return of strength will. But you don't need a whole lot of strength to actually walk. We do need a fair bit of strength to get out of the chair, but once we're up, we don't need a whole lot of strength around our hips or our knees to walk. So those things happen in parallel.
Hi, as a pharmacist working with Rick's Surgery Health Solutions, I would like to add one comment only about medications. Certain medications and their side effect may major risk factor for falls in seniors. So checking with your healthcare provider is very important to know the safety for the medication that you are currently using, and that may cause risk factor for the falls for you.
Very good point, and I think the websites that we've mentioned this evening do get into some of those details on medications.
How much of balance is done by reflex? For example, if you ride a bicycle, it might look easy, but the first time you try it, you find out that it isn't so easy. So your body has to learn how to balance on a bicycle. Is that all reflex?
No, certainly there is a learned component to that. Again, the ability to execute these movement, so on your bicycle example, the ability to execute those movement patterns, that is really initially the learned movement is the anticipatory or the proactive control. Being able to get up on the bike and be able to get enough velocity or forward velocity that you maintain an upright position. Same thing kind of holds true for walking as well. So much of that is sort of, some people actually argue that it's completely, and I'm going to get very geeky on you for a second here, it's spinally mediated, meaning that your brain is actually not involved in the actual generation of the walking pattern. So it's completely not brain related at all. So that's a possibility. There's a lot of contention around that. But the bike riding example that you give, half of that, or maybe, I don't know, it's tough to give an exact percentage to it, but a component of that is that learned movement pattern. And then the other component is the ability to stay upright if you hit a pothole, or if a cat jumps out of your path. So that reactive component as well. Same thing occurs in walking. So this idea that you have these movement patterns that we generate, but then on top of that is the ability to generate these reactions to stay upright if you have anything jump in your path, knock you over, or
But if somebody bumps you, you don't think about recovery.
You don't.
That's totally reflex.
That's correct, yeah. And this is one of the reasons why I think that the reactive component, at least in balance, is incredibly important, and potentially more important than the feed forward or anticipatory movements that we make, because this is the component that keeps you upright. So again, in the situation, like you've all had many, many balance perturbations today, but you've all stayed upright because you have the ability to generate those balance reactions. That's, in my mind at least, the most important part. So you can make all sorts of errors in movement, you can be shoved, you can be hit, you can have things dart out in your path, but it all, the final common pathway really is your ability to generate those reactive movements to stay upright. And if you do those well, you'll stay upright. If you fail, then you fall down.
If you want to see a physiotherapist for an assessment, as you described, do you have to have a physiotherapist that has a specialty, or just any physiotherapist could do that?
Well, any physiotherapist can see somebody for a balance assessment. And a lot of what I mentioned was a quite basic sort of functional kinds of assessment. But it is true that some therapists tend to see more of one type of patient than another type of patient. So I do suggest that you might want to check the clinic websites and or phone the clinic and say, you know, this is who I am, this is why I'm interested in seeing a physiotherapist. Is there anyone there that you would recommend that I see? And some of the clinics do say, they give an idea on their website of the types of patients that they most commonly see and what they're most experienced with.
One comment about physiotherapists is that they are quite expensive and a lot of people can't afford them. The other thing is a question. How important with people who have had falls and who have difficulty with balance, how important is it to use a cane or a walker, which is often advised, but sometimes not in something that the patient would particularly want to use? How helpful is that?
It can be very helpful for some people, and it really depends on the reason for that person, why they had a fall or are having falls, and it really depends what are the reasons why that person has a balance difficulty. But if you think about it, when you add a cane or you add a walker, what you're really doing is increasing that base of support, like Dr. Sibley was talking about, by leaning on a table or whatever it is. So that's what that walking aid will do for that person. But it is important that they know how to use the cane properly and that they know how to use the walker properly, that the equipment is fitted for them. So it really isn't just a matter of going down to Shoppers Drug Mart and grabbing something off the shelf. I do really recommend that the person gets some education and gets some personalized input before they use that walking aid. I know I've seen a lot of people using aids incorrectly, and especially getting up and down from a chair, transitioning, turning around things. That's when it's sometimes, they're definitely vulnerable, and if they're not using their walking aids properly, then it's not going to help them.
Where would they get that help?
Well, I would recommend they see a physiotherapist to do that.
I'll just add one piece to that, and in terms of using a walker or a cane, in thinking about what we were talking about earlier, so they certainly can be helpful when used appropriately, but the thing to keep in mind about them is that they are an aid, right? They're making you safe, they're helping you to be safe out in your environment. They're not making you better at avoiding a fall, right? And so that's important to sort of keep that in mind with that balance. And if you think about, when do you want to be challenging your balance? When do you want to be getting out safely? So, on a night like tonight, if is not the night to say, I'm going to train my balance while I'm on my way out to the car. No, that's when you want to be using your cane as prescribed appropriately. So that's an important sort of distinction I always like to pick out.
There's a website the Canadian Orthopedic Foundation produces that has reminder lists So if you've seen a physiotherapist, then it will reorganize the information for the patient. And I found that quite useful. But they seek funding. So although the information is free, you might get a reminder that a donation would be welcome. Yeah.
I just wanted to remind everybody or let everybody know that yes, indeed, private practice physiotherapy can be expensive, but there are physiotherapists working in the public sector in areas called geriatric day hospitals, which are free of charge, and they see many people who are over 85, well, by definition over 65, but many older people who will go through a very specific and system-based assessment to look at balance. So that's another resource for you.
You're getting your steps in today.
I really just wanted to add to that. I think they have to be referred for geriatric day hospital. So they need the doctor to refer them.
You've talked about walkers and canes. What are your thoughts on Nordic walking poles?
I would say I don't know that we have good evidence for them. I don't know that they've been sort of studied in that context the way some of the other interventions have. I would say sort of the same comment with the idea of what a cane could do. Right? So the walking poles are not going to make your balance better. They're not going to improve your ability to avoid a fall. They are helping you to increase your base of support so that you're more stable. So if your goal is to go out and have a nice hike safely and enjoy yourself, then I would say, great. That's not going to be improving your balance by using that. So it all depends on your goal for that particular situation.
Yeah, and when you say not improving your balance, but it may allow you to get through that hike more safely than if you didn't use it.
Physiologically, it's not.
Yeah. A lot of people who use the Nordic poles are using it, I think, for that reason, because they want to be able to do something physically active that's fairly challenging, and this just gives them that little bit of extra support. Often it also adds a little bit of cardiovascular challenge because you're bringing your arms into it. So I think, you know, a person needs to be clear on why am I using these poles, what am I trying to get out of it.
Just a follow-up question. You had said that Dr. Singh that using a walking aid wouldn't necessarily physiologically improve your balance. Will it actually harm your balance, developing a dependency on?
I said that, but John can answer.
I'm under the bus.
Yeah, sorry.
Are you gonna?
Will it create a dependency? That's a good question.
Yeah, so this idea of a dependency, that's a challenging question. So are you talking psychological, physiological? Psychologically, this is beyond my scope, I suppose. So physiologically, dependency, it's tough to say. Could it potentially lead to further degradation of those systems that are important for balance control? Potentially. That's not to say don't use it. Certainly, I think what Dr. Sibley says is important. Use it when you need it, and then those times when you can put yourself out of the comfort zone and maybe push the envelope a little bit, then do that. But do that in a safe environment. I don't think, to the best of my knowledge, there's any evidence suggesting that these can lead to a degradation of the balance control system. To the best of my knowledge, I don't know if you.
They can actually cause falls. We know there is evidence showing that like a walker can cause a trip, right? So there's lots of lab-based evidence around that. So they have their own risks. They have their hazard. They can be hazardous in that way. I don't know of anything that has suggested physiological changes.
Yeah, it's an interesting research question, actually. I may run back to the lab and try to do it.
We have to go get the answer to that one.
But I think it all comes down to what is the challenge for that person and what is safe. And as Dr. Sibley said, if you need to, if it's challenging for you to walk without that walker and you are not safe to walk independently without that walker, then you need to use that walker in order to be safe. And it doesn't matter that your balance is, the only way that you could work on your balance safely is with another individual there for safety. So, you know.
Kate, you mentioned that dancers have physiologic changes to their balance system. What changes?
Okay, you're asking me to dig deep into my memory banks. So a long time ago I used to study reflexes in your lower limbs. And so these are these very quick, very rapid reflexes that basically detect very small changes in the length of your muscle. So when your muscle is stretched, you have these sensors within muscle. Your muscle is called spindles, and they signal. They make a signal saying, "Hey, we've been stretched," and they will stimulate this reflex loop that causes a correction in that muscle length. So if your muscle has been stretched potentially not correctly, or if you've been pushed and that causes a stretch, it helps bring you back, and that's one of the things that helps keep your balance. So there is lab-based evidence showing that dancers are actually able to inhibit these very quick reflexes, and it's thought that we don't actually know why. It's thought that they inhibit these reflexes to help gain a more sort of precise control over the exact position. So if we think about that base of support, when a dancer is on their point shoes, their base of support is tiny, right? And so they need to have very precise control of where their center of mass and where they're keeping that positioning. So they may not actually want to have that very sort of quick correction come in effect as well. I think, don't quote me on this, but I think there's some evidence. I think there's some like platform divers also, and if you think about like the position that divers have to maintain before they do their Olympic dive, there's evidence that they suppress those reflexes as well.
I just wondered, I think I saw a video, it could have been on YouTube, I don't know where it was, but I think it told me that there was a proper way to fall. Is that correct?
So I think we are, to the best of my knowledge, I'm not sure if, and this could, I don't know who's putting this on YouTube, so I can't speculate. But there are individuals, Steve Rabinovich is one of them at Simon Fraser, who's studying the best way to fall, and also age-related differences in the way people fall. Older and younger adults do fall differently, and older adults fall in a way that sort of predisposes themselves to hip fracture. They tend to fall sideways more often than younger adults do. They tend to fall on an outstretched arm more than younger adults do. Younger adults tend to tuck in their limbs and sort of fall on their behinds more than older adults do. So there are these differences in the way that younger and older adults fall. In your question as to the correct way to fall, I guess not on an outstretched arm and not on a hip, I suppose. But that said, there's no correct way in which to do that. You have these reactions when you fall, and much of them are non-modifiable. Well, I won't say non-modifiable, but they are difficultly modifiable, if that's even a correct terminology.
Stuntmen and women in the movie, they obviously know ways to fall out. They don't.
They have the mats that you can't see. And so they actually have tried, so this group that we're talking about, they have tried to train falling, and so they've done studies to see, can we teach people how to fall in ways that prevent injuries? And my understanding of the data is that they try to train them, they do all sorts of practice, and if they don't know it's coming, the training is not transferable.
And I wanted to say something about the hands. I mean, sometimes it's good to fall on outstretched hands, even if you might break your wrists or something, because maybe you don't want to get a head injury.
That's a very good point.
And I'll just add that there is research going on specific to older women to do resistance training and vibration training through the upper extremities to try to prevent the wrist fractures when you fall on an outstretched hand.
There are also people who focus a lot on, like, you can train getting up, right? And there's lots of sort of controversy in fall prevention around what do we care about? Do we care about preventing the fall, or do we care about preventing the injury? And there are some researchers who say, I don't actually care if you fall. I only care if you don't injure yourself. Everyone's going to fall. And that's quite debated. I don't think we need to go there tonight. But those people will say, you know, part of their fall prevention training is training on how to get up. And there's some good resources on the WRHA web references I gave you that talk about, okay, what to do if you fall and how to take your time and get up and things like that. So you need to think about that too.
I think that learning how to fall is a very important developmental task. I was a pediatric physiotherapist for a number of years, and that was one of the things we would oftentimes see children who had chronic illnesses, lengthy hospitalizations, different conditions that meant that they had to be in a cast for a long period of time. And one of the things we had to do was, in a safe situation, teach them how to fall so that they had that confidence, because they didn't. Normally, toddlers learn it as they're learning to walk, but if you have a situation where you're not able to go through that stage, they were really at a disadvantage when they had to go and start school or daycare with other kids pushing and shoving. So I think it's something that we probably take for granted. We learn it so early, we don't even think about it. But like I say, there are situations where people don't get that opportunity, and they're really having a problem.
Yeah, I was just wondering, how about loss of hearing? Because I remember when I first lost hearing in my left ear, that was about 8 years ago. I was running into some walls sometimes, and I was wondering about, and maybe people aging also with their loss of hearing.
Yeah, it is true that definitely hearing part of your vestibular system, even just the buildup of wax in the ears, can affect people's balance.
And also your ability to detect your own body position in space. So you say you're running into walls, so you have the reverberation of sound off walls, and then you're able to hear that in the ear closest to the wall, and you can detect your own position in space from your hearing, similarly to as you do with your vision. And so that may be one of the reasons why you were running into walls, is that you couldn't actually hear where the wall was, in a strange way of putting it.
I heard that as you get older, your brain shrinks, and that space that's left between your brain and your cranium could cause an instability. Is there any credibility to that statement?
That is the first time I've ever heard. If either of you have any insight, that's
Is
the
that
first
on
time
YouTube
I've heard.
also?
Definitely the brain shrinking part is true. Whether that in and of itself, because your brain is just moving around in there, I don't know how
I would think the other aspect of falling has to be human behavior. If you take two equally able people and they go on a walk through the forest, and one sees the birds and the clouds going by, and the other watches every step, and sees the roots and the potholes, obviously one falls more than the other. And or if you take all the people that have fallen and ask them, and it was 20/20 hindsight, many would say, I shouldn't have done this, or I should have worked out for this, or I should have done this. So how much do you take human behavior and teaching different human behavior, or better human behavior, or focusing on what you're doing, concentrating on not falling, how much is that an aspect?
Can you take it from a training perspective?
I think once somebody has had a fall, then they are just naturally a lot more conscious of what they're doing. So they do start to think about it a lot more, and sometimes that fear of falling almost can be restrictive for them, and that they won't actually experience an appropriate safe challenge that would be good for them. So we don't, we certainly, you know, educate people about things to look for in their home and in the outdoor environment, but we don't normally need to, other than in someone who's actually experiencing falls, normally we don't need to dwell on it a whole bunch because it is quite primary in their minds.
Certainly I think there is a lot of variability in behavior. I think that's an important point. I just look at my own 2-year-old son, for example, and so he is not paying attention with anything, but he falls all the time. And it's not because he has an inability to execute these balance reactions, it's that he's not paying attention to what he's doing. My mother-in-law, my wife's probably going to kill me for saying this, but in the past 2 months she's fallen twice while playing tennis, and certainly this isn't a fall during an activity of daily living, but this is because she's not, well, she's 71, I believe, and she thinks that she's playing tennis at the level of an 18-year-old, but she's not cognizant of the fact that she's not able to dig those balls out of the corner anymore that she once was. And so this is a behavioral issue. It's not, she's in fantastic health, and she's, you know, got very strong upper and lower limbs. She's, you know, not at any risk of falling during any typical daily activity, but you get her on a tennis court and her behavior changes. And I think the same could hold true for people in, you know, as you say, walking through the forest. So it's a behavioral issue as well. I'm not sure if we've studied this all that much. I'm trying to tease out the differences between some of these physiological mechanisms and some of the behavioral mechanisms. Certainly there's a lot of interaction there, but I don't know if we've been able to tease out those two components very well yet. Anyways.
I just wanted to get back to this gentleman's question over here and how much of the neurological training that we get in our experience, though, related to lifestyle. How much of a bank do we develop, you know, as far as balance? So the type of lifestyle we live, could that have like almost like a bank? And I get back to YouTube again. Because I was interested in Parkinson's. There was a video on this gentleman who has Parkinson's, and when he heard music and dancing, he overrode all the different symptoms that he had and was dancing in perfect balance. So, like, how do we, is there any way we can trigger those kinds of neurological training?
So it depends. So with regards to your first question around how does our behaviors early on and our training early on, I think that's a great question. That's a hard one to answer because that's a hard one to study. So that's my dream study, but that would require funds to follow people from very early on in life all the way throughout life to be able to answer some of those questions. So we don't have good evidence yet exactly around how that sort of comes into play. There are new studies going on, so if any of you have heard of the Canadian longitudinal study on aging, they have some balance mechanisms, balance tests in them, so we might be able to start to tap out on some of those. So they're always looking for people. And your second question, with regards to Parkinson's and the movement, so people with Parkinson's have a very specific neurological deficit in a part of their brain known as the basal ganglia. And yeah, there's these really sort of powerful images that you see and stories that you hear of them sort of regaining short-term function when they hear music, when they see patterns on the floor, things like that. And what that is that's essentially they're able to use a different part of their brain to control their walking and mobility in that sort of specific instance. They're basically able to sort of reroute what is happening in order to make that happen. And that's a very specific behavior. That's a very specific issue to people with Parkinson's. I don't know if anyone wants to add anything on that.
Okay, we have time for one or two more questions or comments.
Excuse me, I've got a question on shoes. I don't know if anybody can answer this, and I'm asking the audience too. For tonight, does anybody have a really special pair of shoes that they're just not going to go out on the ice without them? Does anybody have any comments on broom ball shoes or shoes with snowflake ratings? Thank you.
Do you want to answer, Michelle?
Well, I've got my things on my boots. So these are just add-ons. The one thing about them, though, just to warn you, that it's nice when I'm walking around on carpet like this, but when I was in the mall, I was kind of walking like this, like I was on ice because it's slippery. But outside, they're great, but you do have to be careful inside. In terms of boots, there is a group in Toronto. They have a big virtual reality simulator, and they're actually testing boots and in different circumstances to see which kinds of surfaces are better. So they have been making some findings in UK.
So so this group in Toronto has tested boots in winter conditions, and last year they released some of their findings to the media. And they did come up with recommendations for 1 or 2 boots that met their standards for reducing slips. I don't know them off the top of my head. But I think if you were to Google that, I know it was covered by CBC News, and so there you would be able to find some sort of, if you search sort of winter footwear research, it's a group from Toronto Rehabilitation Institute. You'd probably find them. Oh, has anyone tried them? I have not.
One last question, comment? If not, we'll wrap it up there then. Again, there's refreshments up here. There's pamphlets here. Don't forget to fill out your evaluation form. Janine, I think I have some... I have a few things that Janine would like me to say at the end. There isn't a date yet, but the next Café Scientifique is titled Not a One-Hit Wonder, Statins Benefit Beyond Cholesterol. And there is a climate change symposium that's taking place at the University of Manitoba Fort Garry campus. It's on November 23rd, and are there still materials there somewhere? Somewhere there's materials? Oh, they're all gone? Okay, so you can check the website. I think it's free, but you need to register, is that right? Okay, and yes, fill out the evaluation forms and enjoy your evening, and don't fall on your way home.